Assalamu alaikum. Good evening, everyone, and welcome to the first episode of Be Ready Emergency Medicine podcast. I'm Dr. Fahad Al Haddad, emergency medicine specialist, and today we are going to speak about one of the most interesting cases in the emergency department. We are going to speak about the point of care ultrasound and the detection of the shock type in the emergency department by using the POCUS or the point of care ultrasound. As we are knowing that the ultrasound by its variety, we have many types of ultrasound, the main machine or the fixed machine ultrasound, the big one, and we have also the portables and the butterflies. All of them actually is using in diagnosis and assessment, sometimes life-saving, like the topic we are going to speak today for the shock detection. So it's very important nowadays for the emergency medicine doctor to be well trained and qualified to use the ultrasound, especially the POCUS and the point of care ultrasound, to make it easy for the emergency doctor to deal with the cases, and sometimes also to save life, saves money, and also save time. So it's very important tool, the ultrasound. So let's go directly to our today's lecture or today's podcast. We're speaking about detect the type of shock in ED using the POCUS. So we know, of course, that we have four types of the shock: hypovolemic, cardiogenic, obstructive, and distributive. So this is the four types of shocks that is known to all the emergency doctors. And while you are assessing the patient, like you are making an assessment for any patient and you have a suspicion, so you can differentiate them within a minute by using the point of care ultrasound, by using the POCUS, through a protocol that we will speak about now. This is called the rush protocol or the rush exam. What's the meaning of rush protocol? It's the rapid ultrasound, ultrasound for shock and hypertension. Again, this is only four words. The word of R means rapid, U is for ultrasound, S is for shock, and H for hypotensive. So it means rapid ultrasound in shock and hypotensive. This is the protocol that we will use to assess the patient and to detect the shock that the patient is already in. So we're going to use the rush protocol now. But how are we going to use the rush protocol? Three main words that you will never forget. You need to memorize it well to start using the ultrasound in the rush protocol. First one is the pump, second one is the tank, and third one is the pipes. Pump, tanks, pipes. This is the places, or this is the initial or the words that we are going to use while we are making assessment for a patient with rush protocol to detect shock. So again, pump, tank, and pipes. What is the pump? The pump is the heart. So we are going, first of all, to put our probe ultrasound at the heart with its all known position, like the four chambers, the sub-exavoid, the short axis, the long axis. So we are going to see what to look at. We want to look for four things. First of all, the left ventricle contractility, or the contractility overall for the pump, for this pump. Is it pumping well or not? This is for the heart overall. The second one is the right ventricular size. The third one is for pericardial effusion, and the fourth one is for the IVC, inferior vena cava. So left ventricular contractility, or the contractility overall, right ventricular size, pericardial effusion, and the IVC, the inferior vena cava. So what we need to detect from these four parts in the heart. First of all, for me, if there's a poor contractility from the left ventricle, and the contractility is not that much good, which means we are having a poor contractility, and the pump is not working so well, so we are facing mostly cardiogenic shock. This is according to the contractility. Another thing, that if we are having a dilation or dilatation, dilated right ventricle, which means maybe this is we are having a massive pulmonary embolism, which means this is obstructive shock. When we are having a pure dilated right ventricular in the heart, so means this is we are in front of a case, could be massive pulmonary embolism. This is one of the signs of the pulmonary embolism in the ultrasound or in the rush exam or in the echo. The difference in words, but all is the same meaning. So we are speaking about massive PE or obstructive shock whenever we are having dilated right ventricular. If we are having a pericardial effusion plus right ventricular collapse, what that mean? That means it's also obstructive shock, but maybe this is a cardiac or pericardiac tamponade. Again, a pericardial effusion plus right ventricular collapse, that means that we are facing maybe a pericardial tamponade, and also this is an obstructive shock type. This is for the pump, for the heart. So what about the tank? Tank means the volume status, or how much the tank is full. And this is very important that we will be focused on the IVC, the inferior vena cava. This is very important part in the rush protocol and in the POCUS in general. We want to speak about the collapse IVC. What that it means? Collapse IVC means there is no pump, that the tank is not full. Means whenever that the patient is taking breath, there is no, like, the IVC will still collapse and will not take it out or take it over. So which means we're having a collapse in the IVC in measurement that more than less than 50% of that means we are in front of a hypovolemic shock. This is called the collapsed IVC. If we are facing normal or variable IVC, which means that the IVC is in a normal way, in a normal in its normal shape, maybe we can see, we reassess the patient again, and maybe we can see a distributive shock, which means that the distributive shock is in front of us. Maybe it's not 100% that the patient or the IVC is collapsed. Again, the pleuritic or non-collapsed IVC can be leading us to tamponade, pulmonary embolism, or cardiogenic shock, which means the IVC, if it's collapsed, it means hypovolemia. Not collapsed, it's not ruling out the other types of shock, which means that the patient could be having a cardiogenic shock in the pump, that there's poor contractility, and he is a cardiogenic shock, the patient, but the IVC is normal. So which means not always the IVC will lead you to the shock type, but at least the collapsed IVC will lead you that the hypovolemia, or the patient is dry and he needs more fluid or more blood, as the case will be. Also, we need to check the free fluid in the abdomen to rule out the hemorrhagic shock, or to rule out trauma of the abdomen, and the lung ultrasound to check the we have to check the lungs ultrasound clues, A lines, B lines. A lines like the dry lungs, and this is of course leading us to hypovolemia or maybe obstructive shock. The B lines means cardiogenic shock, and also the absence of lung sliding means that we are in front of tension pneumothorax or a pneumothorax case. Again, beside the IVC and beside the tanks, also we need to check the free fluids in the abdomen, means the Morrison pouch, the splenorenal, the pelvis, we need to check the fluid that maybe we can rule out trauma or hemorrhagic shock. The lung ultrasound, we need to check from the lung ultrasound, which means extended. We can say about it extended fast. Fast is for the abdomen, focus ultrasound for abdomen, but extended fast is for the lung. And the lung to see also if we are having absent in lung sliding, means this is tension pneumothorax. If there is A lines, means this is dry lung and maybe can lead us to the hypovolemia. B lines bilaterally means we are in front of a cardiogenic shock, or maybe the patient is on pulmonary edema. So this is called also this is considered from the tank. So the tank to check is the IVC, abdomen, and the lung. That's fine for until now. This is the second part we already spoke about. The third part for us is the pipes, and that's mean the vessels. The vessels for us means the aorta and the lower vessels to rule out DVT. Again, the aorta for us means to rule out aortic aneurysm and aortic dissection through the pipes, which through the ultrasound, through the vessel to measure it, and if it's leading us to aortic aneurysm or aortic dissection. For the lower vessels to rule out the DVT, and means that if there is a DVT, maybe you will have an obstructive shock. For example, if you found a popliteal vein DVT, plus you will find a right ventricular strain, that means that you are in front of a case suspected to be pulmonary embolism, which means this is obstructive shock. Another example, if we are having an aortic aneurysm or rupture aortic aneurysm plus hypotension, means we are in front of a hemorrhagic shock or hypovolemia. That's the pipes that we need to see in front of us if we are checking by the POCUS in the rush exam. I want only to say one more thing about this, that you need to check the patient 100% clinically. The POCUS will help you to distinguish and to differentiate between the different types of shock, but this must not lead you to delay the normal or the assessment for the patient of shock. Assessment, treatment, not to consume time. Don't let the time flow without take care of your patient that needs for maybe antibiotics, maybe for fluids, maybe needs for vasopressors, which means your assessment clinically is the gold standard. Plus the POCUS to distinguish and to differentiate between the types of shock. Maybe you, if you are not having the full qualification to use the ultrasound, you are still under training, and you are not having the full ability to do this ultrasound. It means that you need to be back again to the normal clinical algorithms and to continue with your patient as known for the algorithms for shock patient. So this was the main message from our podcast today, that even if it helps you, don't delay or don't ignore the clinical assessment and clinical work. To highlight and to take it home in a message, POCUS transforms guesswork in physiology-driven management and undifferentiated shock. And again, don't delay the clinical work. This is the most important thing to be understanding from our today's podcast. Our today's podcast is over. It was a little bit fast and brief, but it was a startup and we need to keep it up. We will be doing this in bi-weekly. This is what I wish. If I'm able to do that, so I need to do it bi-weekly. So this is the startup, and this was the first topic today. Thank you very much for listening, and wish you a very good day, and we will meet in other podcasts very soon. Thank you and goodbye.